All right, Chapter 25, Urinary Elimination. These are recordings for Module 12. That'll be coming up. And just a disclosure statement, I do not own this material. Under fair use, I'm providing lecture content for only my nursing students using this material. All content within is for educational purposes for nursing students. It does not provide medical advice. All right. So going back to A and P, let me get rid of this. Going back to A and P, when you took A and P, you should have been paying attention because now everything else goes forward from that. So know all the function of the kidneys, the anatomy that's in there, what goes with the kidneys, what goes with the urinary system, the formation of urine, the ureters transporting the urine, the bladder storing the urine, and the urethra transporting the urine out of the body. So this is really important when we get into catheterizing bladders, because it makes sense why you go in an extra inch once you hit gold in the bag, okay? Because you don't want to be in the urethra, female or male. You don't want to be in the urethra, so you go in at least an extra inch or so, blow up the balloon, and then the balloon sits right there at the bottom of the bladder. Okay, so this also tells you why urinary tract infections go rapidly to sepsis, because this little tract ends up filling the bladder gets infected, goes right up the ureters, straight into the kidney, and you're septic within a few hours. Okay, remember this is your aorta. Remember all that? You should. Remember where your kidneys are. Remember where your adrenals are. The little hats on top of your kidneys. So things are very, very connected in here. If you don't remember, go back, reinvestigate that thought process, because this is going to be huge when we're talking about urinary system. Okay, so the process known as voiding or micturition. Micturition would be another word that you might see on the test if you don't know what it means. Hence, the question is going to be a little harder. So that process, the bladder fills. A bladder can hold 200 to 450 mils of urine. So when we straight cath and get 500, that means that we've really stretched the bladder wall. If you keep doing that over time, that's going to cause issues. If you get less than 200, that also tells you something may be wrong, because you're not filling the bladder like you used to. So activation of the stress receptors, the signaling to the voiding reflex center, that tells you that you gotta go. Contracting of the traducer muscle, and then conscious relaxation of the external urethral sphincter. Have you ever wanted to pee and can't? Because you have to consciously relax that sphincter. This is why there's issues when you say, oh, just give her a bedpan. It's not the same. How many years did they spend trying to get you to not pee your pants? So infants, just think about the lifespan with urination. Infants are going to produce 15 to 60 mils per kilogram. They produce 6 to 8 wet diapers a day. They could produce up to 10, but 6 to 8 is how we usually tell a mom and a dad that they're doing just fine with breastfeeding. No voluntary control. So you cannot expect them to hold it. That doesn't happen until 2 to 3 years. Children, we have that toilet training. Toilet training requires a mature neuromuscular system and adequate communication skills. And problems include enuresis and nocturnal enuresis. So that's bedwetting at night, and enuresis, bedwetting. If it's not during the night, peeing their pants. Enuresis, lack of control over those muscles. Older adults, you have kidney function issues because the kidneys start decreasing in functioning, which increases their blood pressure, right? Urgency, frequency, loss of that bladder elasticity and the muscle tone. So that's why they're peeing at night. And incomplete emptying, because they've lost that elasticity, probably because they were nurses and didn't pee all day. Some factors affecting urinary elimination: personal factors, social cultural factors, environmental factors, nutrition, hydration, activity level, medications, surgery, and anesthesia. So think about some of these. Environmental. Can you always pee? Some people cannot pee outside their house. They have to be in their own bathroom. Nutrition can affect urinary elimination. So if anybody's ever eaten asparagus, beets, you know what I mean. Hydration level. So if you're not drinking any water, how are you going to have any pee? Activity level. Medications. Medications can affect urinary elimination. Surgery and anesthesia. It may take a couple of hours for your bladder to wake back up. So you usually come out of surgery with a Foley catheter. And then they'll get you up to the bathroom. The next morning, we'll pull the Foley. Because surgery and anesthesia can put your bladder to sleep as well. Some pathological conditions with urinary elimination: bladder kidney infections, kidney stones. What's another name for kidney stone? Stone usually ends in lysis. Okay. Hypertrophy of the prostate. Hypertrophy of the prostate. TURP. Transurethral resectioning of the prostate. So if the prostate gets real big, it might cut off or, how do you say, kind of like arteriosclerosis. The fat plaques in your blood system also happen coming out of the prostate. So they have to go in with a Roto-Rooter and plane that down. Mobility problems can affect urinary elimination if you're bedbound. Decreased blood flow through the glomeruli. So what would cause decreased blood flow? Think about this. Hardening of the arteries. Neurological conditions can affect urinary elimination. especially an injury to L1 and 2, lumbar, thoracic, communication problems, and alteration in cognition. Okay, so you always start with assessment. So get a pure nursing history, physical exam, diagnostic procedures. What kind of diagnostic procedures? An IUP. So they'll shoot dye into the urethra and follow it through the system. They shoot dye into your IV and watch it. Just make sure if you have somebody going for one of those tests that you let them know that the contrast will make them feel like they've got to pee. It will have a warm, tingling sensation like they're going to pee the table. Urine output. So you want to get a good history. How long has this been going on? Does anything make it better or worse? All the usual questions. Some of those common urine studies, a freshly voided specimen, a clean catch. So a clean catch is different than a sterile specimen. A clean catch is you giving them the jar and the wipey and they go do it. But it could be contaminated. So a clean catch can be even collected by a CNA. Clean catch. Clean catch. Think about this. When you put a Foley bag to the bedside, only the first urine is sterile because the bag just came out of the kit. After that, if you're taking a urine from the bag, it is not a sterile specimen anymore. It's a clean catch. If you're just dipping for nitrates, that's fine, but not to send it for a UA-CNS. CNS means culture insensitivity. It has to be a sterile urine. UA can come from the bag. UA can be a clean catch. Know the difference. And then a 24-hour urine we do on adults that are complaining about pain in their urine, pain upon urination, but we also do it for pregnant patients to see how much creatinine, BUN and creatinine, is coming out of the urine for 24 hours. So, interesting fact about a 24-hour urine. You've got to know when it starts. Okay? So think about this. If they just peed and they hand that to you, that does not go in the container. You throw that urine away, and this is the time that the clean catch, the 24-hour urine starts. The next urine and everything else for the next 24 hours goes in the jug. If you take this urine, you don't know when that last time that they gave you urine was, so you're not catching that hour of time in there. So when you do a urine 24-hour, they pee, you throw away that first urine. 24-hour urine has to be on ice, so we usually go ahead and leave the container in the bathroom on ice. So every once in a while you have to go check and make sure there's still ice, because that needs to be the chilled urine going down to the lab. So you will see, if you're in OB, you will see people come in throughout the day and they'll leave you a jug of urine on the counter to send down. And then we'll find the results and get them back to them. So it tells you the creatinine clearance, the BUN, how much protein they're kicking out in a 24-hour period. So protein in the urine is a problem. If it's very high, it can signal that a mom has gestational hypertension. All right, so just a regular UA dipstick testing, specific gravity. That's easily done on a urine. Does not have to be a sterile urine. And you're just dipping the stick, waiting a couple seconds, and then you're putting it to the bottle to see where it lines up. So you line up the colors. It's pretty much at the end of there. The yellow, the blue, and the peachish color right there on the container. So you just write down the pH, the nitrates, the glucose. All right, so some of the nursing diagnoses that come from the urinary system: risk for infection, impaired urinary elimination, readiness for enhanced urinary elimination, urinary incontinence, which could be functional, reflex, stress, urge, or risk of urge. So you need to know those and why they're different. Functional urinary incontinence, reflex, stress, urge. So once you've had more than one kid, one baby, you're at risk of urinary incontinence when you sneeze, laugh, etc. Urinary retention, that means you can't go. Sometimes that's a sign for a urinary tract infection. Urinary tract injury. So why would you be at risk for urinary tract injury? Okay, think about these. Planning outcomes and evaluations. So kidney function, urinary continence, urinary elimination, tissue integrity, skin and mucous membranes. So you want to make sure the tissue integrity. If things are swollen, like from having a baby, that could cause functional urinary incontinence. All right, let's think about this. Your patient seeks healthcare for pain in their lower back and fever with chills. They also report experiencing a strong, urgent, persistent urge to urinate, burning with pain when they urinate. You collect a clean catch specimen for culture and note a strong odor and cloudy appearance. The dipstick is positive for RBCs, leukocytes, and bacteria. If it smells like a urinary tract infection, it probably is. What does the nurse know about how a kidney infection develops? It goes up the tract. So a urinary tract infection becomes a kidney infection very easily. What does the nurse do to manage the symptoms? Antispasmodic medication, because usually the spasms are causing the pain. What else do we do? Cranberry juice. What ways could the nurse show caring? So providing hydration. Strong, persistent urge. It'll get better once you start the antibiotics. Education, education, education. What other education might you want to provide to this person to come in and be seen if this doesn't get better with 1 or 2 days of antibiotics? Might need another different antibiotic, okay? Because it will go up that track very, very quickly. All right. So a female client states to the nurse, "I'm so distressed. It seems like every time I laugh hard, I wet myself." The nurse knows that this condition is known as stress incontinence, urge incontinence, functional incontinence, or unconscious incontinence. Which one? Are you putting stress on the bladder? Make your decision. Which one? So, stress incontinence results from increased pressure within the abdominal cavity. So it's not that you're under stress, it's that you're putting your bladder under stress. So every time you laugh, every time, right? This happens to women that have had a child or two because their muscles are not tight anymore. Think about what we talk about with moms. Kegel exercises. Kegel exercises help strengthen the pelvic floor. If you put stress on the bladder, it's going to leak if it's weak. Okay. All right. So providing help for normal urination. What do? We provide privacy using curtains or doors. So think about this though. That's also a safety risk. If you shut the door, you won't see them trying to get up. So providing privacy sometimes sounds more like standing outside the door with your ear to the door so that you can hear. Assisting with positioning with men, it's going to be standing. And with women, it's going to be having them seated straight up. So if they were peeing in bed, that would be more helpful. But think about this as well. If they have a broken hip, that's probably not going to be possible. Either one, female or male, because you wouldn't be able to seat them straight up, females. Facilitating toilet routines, identify the client's pattern. Remember if they're wiping themselves in bed, if they're bedridden, providing a warm cloth after to wash their hands. You're promoting adequate nutrition and fluids. Fluids. Push the fluids. And assisting with hygiene. Assist. Sometimes we also have to give them a washcloth to wash their hands after. All right. So alterations in urinary elimination. So some of the things that might come up against this on the test: urinary tract infections, urinary retention, urinary incontinence, urinary diversion, or urostomy. So I can tell you that every single one of these could be on the NCLEX. Urinary tract infection, they love to tell you 4 or 5 different things, and it's a select all that apply. Well, what would you think that you would tell a patient about preventing urinary tract infections? You should be able to reel 5 right off the top of your head. Wipe front to back, cotton underwear, don't go more than a couple hours without going to pee, drinking lots of fluids to push through the tract. The more they drink, the more they pee, right? You should be able to come up with 4 or 5 different things. With a kid, I will warn you that urinary tract infections usually happen because we're not wiping front to back, but also that constipation can cause urinary tract infections. Think about this. If you have hard stool in the colon, it presses on the ureter. They love to get you with that one for kids. Prevention of constipation. Urinary retention, again, constipation can cause urinary retention. Urinary incontinence, usually an older person losing bladder wall functioning. What do we do for that? Kegels. Urinary diversion is a urostomy, so they have an opening to the skin. The stoma is sutured to the wall, and there's a catheter that goes in and collects that urine from time to time. So you may have to do this as a nurse if they can't. But you see the ureters are implanted into this little pouch, so they make them a new little bladder. The pouch is created from a segment of ileum, that's small intestine tissue, the beginning of the large intestine. And the fluid pressure closes the valve for us. So you go in with a catheter to get that urine out. So you can see you really have to make sure that you push it in a little bit more so that you get the urine in the bottom. They would be standing over the toilet if they were self-catheterizing. Monitor for distension. Measure the post-void residual. What is a post-void residual? Exactly what it says it is. After they've voided, you use the bladder scanner and you scan the bladder for the residual urine left. If they ask you to get that urine residual, then you use a straight cath, go in and drain the rest. Being most invasive to least invasive, you would want a bladder scan first. And then if there's none in there, you don't need to do the catheter. Every time you go in with a catheter is an increased risk of infection. Drain the bladder. So we use straight caths, we use indwelling Foley catheters, and suprapubic catheters. So suprapubic, above the pubic bone, a catheter. So suprapubic catheter is a catheter coming out of the body above the pubic bone. So the catheter is straight in the bladder, draining to a bedside bag, just like a Foley catheter. All right, regardless whether it's a straight cath or an indwelling catheter, it's the same procedure, okay? Exact same procedure, it's just that the straight cath just goes in and comes back out, and the Foley catheter stays in. All right, so here's the difference between your straight cath. So you can see this straight cath has no balloon because it's not staying inside. The other ones, if it has two ports, one is the balloon and one is the urine. So the balloon gets inflated with water that comes in the kit, versus an irrigant balloon would have two ports going down that are not connected to a drain bag. So one gets blown up with the balloon. The other one is for irrigant. Irrigant is usually NS, normal saline solution, that washes out the bladder lining. Why would we do that? To keep blood clots from forming after a TURP. So when you Roto-Rooter, when they plane the surface of the prostate, it's going to be chunky, full of tissue, and full of blood clots. So in order to get those blood clots to come out, you're irrigating it, and it's coming out through those catheter tips, but it could block it. So you're constantly irrigating the bladder to get the blood to flow out instead of making clots. So you've got this to the bedside. One is a 3,000 cc bag to an IV pole that's irrigant, flushing the bladder, and then the urine is coming out the Foley catheter. So you've got to be one-on-one basically with that patient, because you're constantly going to be emptying the Foley catheter. The irrigation is just going to be free-flowing. All right, so teaching the patient to use Credet's maneuver. Credet, what does that sound like? What is that? Credet maneuver is like thinking about pushing down with your bladder, but you also use your hand to press down on the bladder. So when you're straight cathing, you will say, press down on your bladder, and you're kind of massaging the bladder wall through the abdomen. Teach patients to do pelvic floor muscle exercises. What are those? Kegels. Kegel exercises, male or female. So how do you teach a patient that? You tell them to pee and stop the flow, pee and stop the flow, pee and stop the flow. So every hour they might do 10 of these while they're watching commercial TVs. The TV is on a commercial. They're literally using those muscles and stopping the flow. Advise a patient to contact healthcare professional if have a complete inability to urinate, having fever, vomiting, pain, and chills. That's the urinary tract infection. And blood in the urine. There should not be blood in the urine. If there is, that's a key indicator that something's wrong. Blood in the urine will cause nitrates to occur. Nitrates also occur naturally. Okay. So managing urinary retention, you're providing care for the urinary catheter. Make sure that you prevent urinary tract infection. And when we go to put Foley catheters in, you'll understand that a lot better. Maintain a free flow of urine. So think about putting the bag on the side of the bed, not in the bed. Free flow of urine. No kinks. Prevent transmission of infection. So that's peri-care, catheter care. Promote normal urine production. Hydration, hydration, hydration. Maintain skin and mucosal integrity. Not pulling on that catheter. Taping it to the inside of their leg. You don't want to have traction on it. All right, so a nurse prepares to insert a indwelling urinary catheter. Which statement explains the reason for this intervention? I'm going to empty your bladder prior to your procedure, not indwelling. Treat your problem of leaking urine, no. Obtain a sterile urine specimen for culture, no. Okay, so herein lies the problem. Okay, think about this. Think about this. Which ones would I use a straight cath for, and which ones would I use an indwelling catheter for? Measure the amount of urine left after you empty your bladder. You're probably not going to use an indwelling catheter if it's not staying in. So the only one that makes sense at this point would be A, but you're leaving it in there, okay? So if you're just going to empty the bladder, we would probably use a straight cath. But because it says prior to your procedure, yeah, we're going to go ahead and put the straight cath in, but leave it to a Foley bag. So that could be a chance to use an indwelling. Treat your problem of leaking urine is never the reason to use a Foley. Obtain a urine specimen for culture. That's a straight cath. Measure the amount of urine left after you empty your bladder. That's a straight cath. Okay, so that's how they're trying to trick you with this question. If you need a straight cath, you need a straight cath. If you need an indwelling urinary catheter, you're leaving it in there, hence indwelling. Okay, so watch how they're trying to get you. How are they trying to get you? Which statement least explains the reason for this intervention? Least, meaning except, right? Except. All of the following except. Treating your problem of leaking urine is not a reason. for a catheter. They're trying to see if you understand why you need a catheter and why you don't. Whether it's a straight cath or an indwelling, it's still a catheter. This is the only one you would not use a catheter for. All right, managing urinary incontinence. Preventing skin breakdown. So if someone is always wet, they're going to have skin breakdown and maceration of tissues. Encourage lifestyle modifications. What would lifestyle modifications be? Think about this. So wiping front to back, things like that. Hygiene needs, things like that. Implement bladder training. One of those lifestyle modifications that they love to use on the test is going to the bathroom after sex to wash out the track. Implement bladder training. Bladder training is making sure that you're peeing every couple hours. Don't let it go too long. Encourage the client to perform your Kegel exercises and using anti-incontinence devices where needed. Anti-incontinence devices. Condom cath, Pure Wick, right? All right. Some strategies to promote independent urination. Pharmacological. So there are medications that tighten the sphincter for boys and for girls. There's surgical interventions like pulling up the bladder, pulling up the abdominal cavities, a sling for the bladder, pessary devices. So parental teaching for enuresis. Parental teaching for enuresis usually sounds a lot like provide medications prior to bedtime, make sure that they don't miss their medications for bedtime. Also, that it's normal and not to focus on it as much because it can take up to 3 years to be fully potty trained. The other parental teaching for enuresis is that regression can occur. So kids that were fully potty trained, when they go to the hospital or something happens, they can always regress. So a kid out of nowhere starts wetting the bed again. All right, so using Socratic reasoning, you're caring for a frail older woman with overflow incontinence. What physical and emotional issues would you expect her to also experience? Overflow incontinence. I'm so embarrassed. I don't like the smell. Right? Physical and emotional issues. She just has no control over it. It's a nice thing when they can't smell themselves, but everybody else can. So they're very subconscious about it, self-conscious about it. All right, there's a 24-hour urine collection in progress. The unassisted licensed personnel inadvertently empties one specimen into the toilet instead of the collection hat. What should you do? Continue the urine collection until the 24-hour time period is finished. Make note to the lab to inform that one specimen was missed. Begin filling a new collection container and take both containers to the lab at the end of the collection period, or dispose of the urine already collected and begin an entirely new 24-hour collection. What would you do? The question is it now a 24-hour collection if we're missing part of that collection, right? So A, B, and C are sounding awful lot alike, but D sounds very, very different. So what do you think you would do? We have a little thing in nursing called when in doubt, throw it out, because it's probably the safest thing to do. You're going to ruin the results of that urine if you don't have all the urine in the 24 hours in there. Okay? So throw it out. One missed specimen is important. It's going to make it be inaccurate, and the collection has to be restarted all over. That's why you have multiple signs in the room and in the bathroom to put it in the collection. This is a staff error. Now the patient has to stay even longer to do the full 24-hour collection. That's why you put multiple postings all over the room to be sure that we put all the urine in there. Okay. So diversions, just also know your diversions, the types of diversions, assisting with aspects of care and psychological support. So this is going to sound an awful lot like a colostomy. They must be able to look at it, assess it, be able to cath themselves, or be able to change the bag or change the catheter in order to go home. So this is your urinary diversion. So the ureters now go into this tube, and the tube is sewn in one end to the skin, and they form a little pouch. Okay. So know about your diversions and what kind of diversions there are. There are multiple, but it's one more way to get urine out of the body and for storage purposes. So they could have a bag inside or they could have a bag outside. They could have a catheter coming out of their body all the time, or they could have to go self-cath in the toilet. Okay, so a lot of people do these things at home, so there's a lot of education. So once you know how to put in a Foley catheter, it's all about how to teach this patient to do the same. All right, talk to you later.